Hello, everyone. This is the satellite session at the TCT 2022, coming to you from the World Connect Center. Welcome those who are in the audience here in person and those online around the world. The session today is a leap into the future of DES technology, innovative DES platform combining drug-eluting stent and drug-coated balloon, specifically the Ability DES+, a sirolimus-coated coronary stent system developed by Concept Medical. This promises to be an extremely interesting session. You will today understand the design as well as the novel technology used in this drug-eluting stent as well as drug-coated balloon platform called DES+DCB platform. We will also highlight the ability, the use of the device, and the concepts around its projected benefits in this highly complex group of patients, which is the diabetic patients. The diabetic patients, as you know, has the worst outcomes, both in terms of restenosis, in terms of cardiac events, and in terms of mortality when treated with conventional drug-eluting stents. We will also understand the evidence base and the trials around the Ability DES+, as it has been shown to have certain benefits in the Ability randomized controlled trial, and yet awaited results of the Ability Diabetes Global Trial. So let's move on with this session. We have some tremendous speakers with vast experience on the use of Ability DES+, and I hand you over to my colleague to introduce the session and the speaker.
Sure, it's a pleasure to be here. My name is Joanna Wykrzykowska, one of the interventional cardiologists from Groningen in the Netherlands, and indeed we have an unbelievable set of speakers here and experts in the field. So as first, I'd like to introduce Dr. Fazila Malik from Bangladesh, who will talk about the innovative DES and DCB platform, and she will introduce the technology to us.
So friends and colleagues, it's really a joy to be here today. And today I'll be talking about diabetes and coronary artery disease. Now you all will agree that one of the most frequent comorbidities that we see in a patient who's undergoing PCI is diabetes mellitus. And indeed, in a high-volume single-center registry, they found that around 46.9% of the patients undergoing PCI were diabetic. And when a person with diabetes mellitus develops coronary artery disease, that patient is at increased risk of future cardiovascular events and even death. And we all know that diabetic patients, the coronary lesions are more complex. There is increased necrotic core volume, increased inflammatory infiltrate, and increased calcification. And when we see these arteries on an angiography, these are long, diffuse lesions. Very often the vessels are narrow caliber, and often the vessels are calcified. And before we put in a stent in these vessels, we usually, and we should, of course, always make sure that the lesion is properly prepared, and that takes time. And also when we deploy our stent, very often when we go to high pressures, at the edges of the stent, there is often barotrauma, and that sometimes translates to peristent restenosis. And so, due to the huge inflammatory plaque burden, due to delayed healing, when a patient undergoes PCI with a stent put in, there's always a risk of stent thrombosis, which can be acute, subacute, or late, or even restenosis, which might be focal or diffuse through the entire length of the stent or at the edges due to barotrauma. And let's face it, whatever stent you put, a patient with diabetes after PCI will do poorly compared to a non-diabetic patient. And that's what we always see. And in this scenario, the Ability DES+, which is a sirolimus eluting stent, has come up with certain unique innovations which make it very suitable for diabetic patients. Now, the first is fusion coating. So there's a coating of the stent as well as the exposed part of the balloon, and this addresses the complexity of restenosis, both focal as well as diffuse. There is edge coating, so an additional 0.5 millimeters of coating on the edge of the balloon, and this addresses edge restenosis. And it's abdominal coating, which facilitates monodirectional drug release. And this stent is truly thin strut, so this allows very easy deliverability as well as trackability. And regarding the drug kinetics is such that 50% of the drug is released within the first 7 days, and the polymer degradation occurs in 6 months, and all of this ensures very rapid re-endothelization. And regarding the crimping of the stent on the balloon, in many stent platforms, the stent is first coated and then crimped, which can cause damage to the coating. However, in this stent, it's first crimped on the balloon and then coated, which ensures uniform coating. And as this coating is both for the stent as well as the balloon, this gives a unique advantage for the diabetic patients. So this DES+DCB platform is uniquely suited for diabetic patients, and indeed, it has this CE mark for treating patients with diabetes mellitus. And just to highlight this, I would like to show you a case where we treated that diabetic patient with this stent. Now, this is a 60-year-old gentleman who had chronic angina pectoris. He was diabetic and dyslipidemic with an ejection fraction of 53. And as you can see, his RC is a dominant vessel free of significant disease, giving some collaterals to the left system. The LCX is a non-dominant vessel, diffusely diseased. The LAD is highly calcified with long diffuse stenosis in its proximal to mid segment involving a large diagonal, also severely diseased. Now, wiring the LAD was a bit challenging because of the huge chunk of calcium that was sitting on the initial part of the LAD, and our wire couldn't go through. Finally, we were able to negotiate a pilot 50 wire with the support of a microcatheter, but the wire went into a septal. With very gentle negotiation, we were able to coax that wire to the distal part of the LAD. We changed our wire with the help of a microcatheter for a rota wire, and without further ado, we did rotablation with a 1.5 millimeter burr. After rotablation, at this point of time, we were able to take our IVUS catheter, and as you can appreciate, there's huge plaque burden and almost 270 degrees of superficial calcium almost through the entire length of the vessel. So this vessel really needs working on. But before that, we wired the diagonal one with the support of a microcatheter. After this, for lesion preparation, we further did pre-dilatation with a 2.5 by 20 NC balloon for the entire disease segment of the LAD, and we went up to very high pressures to make sure that a lesion was properly opened up. We did very gentle pre-dilatation with a 1.5 by 15 NC balloon for the diagonal one. At this point, we didn't want any dissections there. We then went on to put in our stents. For the mid-LAD, we took a 2.5 by 30 millimeter abluminous DES. We deployed it at 12 atmospheres, and we kept the balloon inflated for 45 seconds. Now, this is crucial if you want the drug to be eluted properly from both the stent as well as from the balloon. For the proximal part, we took another DES, we deployed it, and again kept it inflated for 45 seconds. We did proximal optimization. We rewired the diagonal with the support of a microcatheter, removed the jailed wire, and then we prepared the lesion in the diagonal with a NC scoring balloon. After that, we took a drug-coated balloon for the diagonal and we inflated this for 60 seconds. We did final kissing for diagonal and LAD. We did a report with a 3.5 by 10, went up to 20 atmospheric pressure. I was showed that the stent was indeed properly deployed. There was no malapposition, no underexpansion, no edge dissection. And angiographically also the lesion looked spot on. And we did this case quite a few months back, and we did a telephonic follow-up of this patient. He's doing fine. He's leading a very active life, but the top bit, his diabetes is also under control, which is crucial for diabetic patients. So in summary, I would just like to say that this unique innovation of a drug-coated stent with a drug-coated balloon, when used properly in a properly prepared lesion, this might be the answer for diabetic patients. Thank you.
Fantastic talk, Fazila. A really great case and also presentation of the technology. So on your IVUS, you show clearly that there's absolutely not a landing zone in diabetic patients which is free of disease. And I think, correct me if I'm wrong, that's probably the reason why this edge dilution is so important, because you can't land in a free zone. What do you think?
Absolutely, and that's one of the problems with diabetic patients. They have such huge plaque burden. The vessels are so diffusely diseased that when you put your stent, chances are that you might land in a disease segment, and that leads to future problems. Yes.
So, Fazila, this is a very innovative technology, a combination of drug-eluting stent and functioning as a drug-coated balloon because of the uniform coating which is on the balloon as well as the stent. Are there any differences? Do we have to inflate the stent for a longer period of time so that the drug from the balloon also delivers to the intima?
Yes.
How the crossing characteristics? Tell us a bit more about the stent itself and its use.
Well, so that is one of the most important features. First of all, lesion preparation is crucial, especially for a drug-coated balloon to work properly. And so, first of all, after proper lesion preparation, this is a very deliverable stent because it's thin-strutted. So once you've prepared the lesion, you usually don't have any problems delivering the stent there. But you have to expand your stent and keep it expanded for at least 45 seconds. Now, doing this in case of like a left main, it usually creates problems. So you cannot keep it inflated for 45 seconds in a left main maybe. There you have to do 2 subsequent consecutive inflations of 30 seconds each. But you have to give time for the drug to be eluded from the stent as well as from the balloon. That is crucial to get great long-term results.
Absolutely. Also, you showed a very nice combination of stenting in the main vessel and balloon technology in the side branch, which might be actually, this blending of technologies might be a nice solution for many patients.
Yes, we don't want to cage all the vessels. That also we should remember, I think. So if we can get away with not putting a stent in a vessel, I think that would be in the long term great for our patients.
And in the side branch, did you use a sirolimus-coated balloon into the side branch, or did you use a paclitaxel-coated?
No, I used a sirolimus-coated.
Mix of...
no, I used a sirolimus-coated.
Thank you.
Now, I think if there are no other questions or comments, we'll go on to the next presentation, and that's the role of imaging in diabetes patients, case presentation from Ability randomized trial, which we heard about, and the presenter is Dr. Antonio Mangieri.
Okay, thank you so much for the kind introduction. So, as mentioned, the role of my presentation will be about, some cases that we have done in the setting of the Ability randomized control trial. I just want to sum up some of the features of this trial, which aims to compare the Abluminous versus the Science stent in 165 diabetic patients randomized in a 2-to-1 fashion. Of course, the inclusion criteria were diabetic patients with lesion between between 2.25 and 4 millimeters diameters, and we had no limitation in the implantation and the number of the lesions treated. The endpoint was basically an OCT endpoint evaluated at 9 months follow-up and was powered for non-inferiority according to the hyperplasia volume found at the OCT. So I will show you some practical cases that we have done in our institute, the Humanitas. You see that the first patient that I want to introduce you is a female, 60 years old. She had a type 2 diabetes, and she had previously received a stent in the mid portion of the RCA. You see that there was some progression of the disease, especially in the proximal part. We went for the implantation of 2 abluminous stents, which were implanted with overlapping with the previous one and up to the ostium. This is the acute result. You see that the angiography looks pretty nice. And if we go to the follow-ups that we did at 9 months, you see that the angiographic results looks quite superimposed to the previous and index procedures. You see in the second film that we did also the OCT as well according to the protocol. This is a long evaluation of the stent. You see that the stent is not under-expanded. It looks like to be well expanded. Here we have some shots which show that there is basically very few little intima hyperplasia. And this is an analysis made by the core lab. You see that the part which was overlapped with the previous stent looks like perfect. We had a very small amount of uncovered struts, around 0.4%. The rate of malapposition was very low as well, like 0.1% of the stent struts were uncovered, were malapposed, and the percentage of coverage was dramatically high, was like 99.5%, which is very important for me also according to the duration of the DAPT in these patients. And you see also that the minimal neointima hyperplasia area was very little, was just 1.1 millimeter square. So let's proceed with another case. You see this diffuse RCA, which was dramatically, I would say, diseased, especially in the first portion, but you see also stenosis in the PDA. Here we went like for a stenting, especially of the first portion, while the distal part and the mid portion, while the distal part was treated with a DCB. So we went for an hybrid solution in this case. And you see the 9 months follow-up, which looks like to be perfect. You see the OCT run, which showed that essentially the result was pretty amazing. We had very little hyperplasia. The shot that he took shows like a normal position, and essentially the stent struts coverage was perfect at 9 months. And the patient for sure was in a good status at the follow-up as well. Just to show also the competitor, we have also this male, 55 years old. It was a very dramatic diabetes, but you see that at the angio, he came for angina, but he had not a dramatic situation. We found just an intermediate lesion of the obtuse marginal. We did an FFR, which showed a positive inducible ischemia in this territory. We went with the implantation of Science Sierra 3.0 by 18 millimeters. You see that the result, acute results looks very nice. The patient came back this time 10 months at the follow-up, and you see at the shots that the result is preserved. So also with the Science stent we obtained a good result. Maybe some disease in the middle portion and some restenosis in the mid portion of the stent we previously implanted. But you look again at the OCT, and the OCT looks nice. Maybe we have some restenosis in the mid tract that was not dramatically significant at the OCT evaluation as well. So just to show another case which was a little bit more dramatic and is a real world case. So this patient was a 76 years old male. As a risk factor, I did not have like the history of diabetic because was not a known diabetic patient, but the diabetic was discovered later on at the follow-up. He presented with an unstable angina, a moderate reduction of the ejection fraction, and a significant rise in troponin. And so this is the shots that we took. You see that the patient had a very diffuse, severely diseased RCA with also an involvement of the left system. Basically, the left main looks fine. We have not so huge circ, which was diseased at the level of the ostium and the proximal segment, but I think that the most dramatic situation is at the level of the LAD and of course also at the level of the diagonal, because we have multiple stenosis up to the mid-distal portion, both of the LAD but also of the diagonal. I will say that here the operator was very traditional. At the beginning we wired, but we had some difficulties in advancing stents and materials, so we went for a rotablation just to prepare the lesion. We pre-dilated using long balloons, both the LAD but also the diagonal, in order to have a good result in this patient. And you see that at the first shot that we made, we found a good situation. There are some dissection, especially in the proximal segment of the LAD and also around the ostium of the diagonal. Maybe around the ostium of the diagonal the preparation was not so good. So the operator decided to stent almost everything. He proceeded with long stenting, both on the diagonal and both also on the LAD using a decay crush technique. So a very strong stenting for I would say a very complex clinical case. This is the final result that we obtained. You see that basically also the intermediate branch was left untreated at this time, also the circ as well, and the RCA, because we decided to call back the patient after 1 year just to see what was going on and to do an angiographic follow-up. And you see that even after 1 year passed, you see that the situation is quite nice. Of course, during the index procedure, we utilized the IVUS to optimize the results, but you see that after 1 year, the situation is good, especially on the LAD. I see no signs of hyperplasia. There are some intimal hyperplasia, especially around the diagonal, but was absolutely not significant. And you see that we were quite satisfied about that. So in our experience, I will say that the abluminous stent seems to have a good performance, both in very simple cases, but also in complex cases, as I mentioned before, especially due to its stent design. I would say that the deliverability is very easy. The stent is clear, visible, and we have obtained good results both in simple but also in complex cases. So the results of the randomized controlled trial are close to come, and we hope to have good news, especially for the next future and for the treatment of such complex patients. Thank you for the attention.
Thank you. Any questions from the panel or the audience? No?
Yes, I do. Those were extremely difficult cases. I think you demonstrated the use of this innovative technology in the best possible manner. And I have a question. I have two questions for you. Firstly, I do understand it's a thin strut, relatively thin strut stent. What about crossing into the side branches? Is that easy? Is that difficult? You showed bifurcations, a complex bifurcation. Tell us more about it.
I think that you have seen that in the later case we have utilized also very long standings, which are quite difficult to be delivered. But I think that the crossability of the lesion is excellent, and especially what we usually do is also to utilize this stent in a very new setting. I mean, we have to release the drug completely, so the inflation should be prolonged. But I think that thanks to this innovative design, sometimes when you realize that the stent landed like in a very diffuse disease, you can also utilize the balloon of the stent also to accommodate the distal landing zone in the diffuse disease, to not create such step-up angiographic images that sometimes promotes also the recoil and at the same time also the restenosis at the distal edge. So I think that thanks to this design and to some new innovative features that we have in such stent, we can treat this patient in a very good and innovative way. The other thing is that even if it's a very thin struts, I found no like recoil and a good stent expansion also in the context of a severely calcified vessel. I mean, sometimes when you have very thin struts, the result, acute result, I mean, is not so dramatically good, but thanks to its innovative design and to the number of struts that we have in this stent, I think that the acute stent expansion is dramatically good also with this.
But there's the question of crossing into the side branches, accessing, putting stents through in a tap or cool-out techniques. Does it become your stent of choice for two-stent bifurcation strategies in diabetic patients?
I think that we had the opportunity also to participate in this global trial, and so we had the opportunity to implant and to utilize this technology in more patients compared to the randomized controlled trial, which I showed in these slides. I think that in the bifurcation lesion is doing great. I tell you the truth that I'm not using the two-stent strategy as default strategy in most of the cases, because especially in diabetic patients, I think is something that should be avoided, because the rate of failure could be higher. I prefer, like in the previous case that was shown, like do an hybrid approach using DCB for the side branch, because I think it makes your life easier, and also for the patient, even if you have not such great angiographic result in the acute phase, you have more satisfactions like at the follow-up, I think.
I think you made a good point. I mean, I think, this technology ensures that you deliver the drug more evenly, right? But it doesn't give you a higher dosage of the drug. So the fact that you have 2 layers of struts proximally in your DK crash is not really increasing your stent thrombosis rate. At least that's the way I understand it.
Yeah.
I think you make a really good point also with your OCT images that these patients, diabetic patients, are also high bleeding risk patients. So the sooner you get the coverage, the better. You showed the data from 9 months. Do you guys have any data from 1 month, 2 months, a bit earlier, to see if we can stop DAPT even earlier?
Yeah, I think it would be very great. Unfortunately, we have only the 9 months, follow-up of these patients. In some cases, we have to discontinue the APT 6 months at the 6 months as recommendation of the DES guidelines, but we have no cases basically of thrombosis or any issues. And I review also some of the results of the randomized controlled trial. I think that the safety of this stent is quite comparable to the science DES. So the strat coverage is a big point that we have to take into account. But I think is an easy stent and is a safe stent according to the DAPT duration. Thank you.
Thank you.
One concern and a question I think it should be well addressed is, of course, this issue about wondering whether we're delivering more dose of the drug than is necessary because we have the balloon delivering the drug at the same time as the stent delivering the drug. Was the Ability randomized control trial OCT guided for all the patients? Was there a control OCT? And my concerns lie about, did you see any aneurysm formation or any adverse events related to double dose of the drug in the Ability randomized control trial? Essentially, what we observed at least in my center, I will say, is that at the follow-up we did not find any aneurysm formation in both the arms. I have to tell you the truth that we had no surprises, let's say something like that.
Welcome, Roxana. She's the PI of the whole global trial. So
so it's a really good question. First of all, I think what we're getting with the abluminous technology is a homogeneous delivery of the drug to the vessel wall. And I think that's something that everyone needs to understand, that the balloon is delivering the drug to the gaps that the stent would have within the lesion and the vessel treated, as well as in the overhanging edges where we believe and we see a lot of restenosis and stent failures due to new intimal hyperplasia, especially in the diabetic patients. I think one of the biggest challenges for us was to take on this question for diabetic patients because we believed wholeheartedly that at the very least we will be non-inferior to the current available best-in-class DES, the Zion stent, but that there would also be a possibility of superiority in terms of target lesion failure that included target lesion revascularization. We do not know about aneurysmal formation. There was no need for an OCT guidance, any of that. And when the patients come back, we can tell you that at the moment, we cannot report anything because we don't have the data, right? The trial just finished. 3,050 enrolled patients. It's the largest PCI trial in diabetic patients comparing two different stent technologies. And I think that's a tremendous, tremendous effort by our investigators, such as Joanna and the team here. And then we've done, and Fazila, Dr. Malik, you did an amazing job. And of course, Cirque is running the trial, and we're just so excited about the fact that we will answer your questions for sure. We do not expect at all any kind of an aneurysmal formation. And by the way, we have we're all blinded. We have no idea what these patients had when they come back. And the Data Safety Monitoring Board is watching over these patients' safety. So far, there's been absolutely no indication or signal of having to stop for any safety signals. I think it's really important to note those. So I wanted to make sure that we pointed those out. So if there was any question that we are on top of this very, very diligently.
Thank you.
Thank you. So without, I think, further ado, to emphasize that this is the perfect match between diabetes and technology, I'll invite Dr. Luca Testa.
Well, thank you very much for this kind of invitation. It's always a pleasure to discuss this kind of a subject with you because, of course, I mean, we started talking about the diabetes a long time ago, and then we're still searching for the Holy Grail in terms of, finding a way to, at least compare results that we got with different approaches like surgery, for example, with the technology that we are using, every day. And I take the occasion to show a couple of extreme cases where I honestly decided to challenge this technology, in particular in those cases where we do know that every single available stent is not going to perform very well. I'll start with this 84-year-old male gentleman with some comorbidities, including a TIA in 2019, a non-critical carotid stenosis, peripheral arterial disease, and some other comorbidities, including renal failure. Risk factors such as dyslipidemia and type 2 diabetes was referred to our Center for Worsening Dyspnea and Angina in non-severe aortic stenosis. The echo confirmed the aortic stenosis and with an ejection fraction normal, mild MR. The EKG didn't show anything very particular, and the pre-TAVR CT scan showed a critical LAD stenosis, which is not an abnormal finding because obviously the calcification involved in the aortic valve may involve the coronary artery as well. I performed this TAVR, actually making sure there was some kind of cerebral protection, nevertheless the data that we just understood today, and it was a good result. And then, of course, I decided to tackle the LAD stenosis and I measured the commissural alignment, which was good. So as you can see, the middle LAD is relatively short. There is a relatively short stenosis, but really calcified. So it was complicated to cross it, but eventually I made it. And then I decided to start preparing the lesion, as we always should do, in particular when we are about to deliver a drug that is going to, try to stop the stenosis and to decrease the risk of target lesion failure. So I used the burr, 125, 1.5, nothing special. And then I actually decided to keep going to a predilatation using non-compliant balloon 2.5 that was delivered through the guide catheter extension, and then the abluminous 3.32, which was actually not that easy to deliver, but I would say there was a combination of several factors in this kind of procedure, in particular the support, as you can see. But anyway, the final angio was absolutely, satisfactory, although there was some kind of little interferences there. So I made some imaging, and as you can see in the left side of the slide, there was some kind of dissection, no flow, little dissection. And then this patient actually came back 9 months after the procedure, and then we observed a complete restoration of the arterial wall. So going back to the concept of safety in terms of the technology, I have to say that I was surprised because there was no signal of bad behavior interacting with the arterial wall. So let me go through the clinical level or clinical case 2, which was much younger, 64 lady, with some comorbidities including mild renal dysfunction and non-insulin-dependent diabetes. The clinical history was complicated as well, so emergency PCI to left main LAD following an anterior STEMI, staged PCI to ostial mid RCA in 2018 with everolimus-based DES. Well-being until April 2022 with uneventful follow-up. In May 2022, exertional angina, she underwent a cardiac MRI showing a large area of ischemia in the inferior wall, so hypothetically the territory of the right RCA. So it was admitted for coronary angio. And this is what I found. The RCA was not there. And there was a huge collateral flow coming from the left system. So all of a sudden, in this case, we always wonder, in particular in diabetic patients, relatively young patients, well, to consider surgery. However, the left system was so good that I decided to proceed. And then actually I decided to tackle the CTO while crossing the retrogradally because antigradally was absolutely not possible. And then I made it through all the path, and then it was absolutely possible at the end. And then I perforated the proximal cap with a CTO dedicated wire. And then at some point had to close the circuit. So I made with a workhorse wire, I made to engage the antigrade catheter in order to close with an externalization wire the circuit. And then I restored the flow, in particular at this stage, using several balloons, I have to say, and that was the situation. As you can see immediately from this image, the main problem was actually related to the distortion of the stent at the ostium of this RCA, as I said. So I decided to deliver, in this case, the Abluminous DES+ 3.0 by 20, and then I followed with a non-compliant balloon 3.5, as you can see here. It was pretty nice, inflated since the beginning, but I've seen some notch here, so I decided to insist. And then a 3.5, which was beautifully expanded. And then I decided to use an hybrid approach. I mean, depending on what is your approach, obviously you can discuss whether it's better to use another stent or maybe a drug-coated balloon to tackle the in-stent restenosis. But at least in my practice, the possibility to avoid the use of more metal is something we should pursue every time. So I decided to use this hybrid approach that included Magic Touch 275 to the prox and the mid RCA, as you can see here. So that was the final result. And I have to say that after some work, just a couple of hours, to be honest, I was pretty happy. So my conclusions after these two cases, very challenging cases, is that the acute performance of the Abluminous in complex setting was quite reassuring. No signals of reduced safety as compared to other available stents. At follow-up, the biological interaction between the Abluminous and the coronary wall in a diabetic patient seemed encouraging as we observed a full strat coverage, minimal hyperplasia, and a smooth healing process of the observed edge dissection. Ultimately, I would say that the hybrid approach with Abluminous DES+ and the Magic Touch has a great potential in extreme situations of previous stent failure and long diffuse disease. Thank you very much for your attention.
Great cases again. So I think it's fair to say that this performs just like any workhorse stent, basically, and except for the fact that we have to inflate it somewhat longer, it doesn't really differ in how you handle the device. I don't know if anybody else wants to comment. Fazila?
No, I agree that it's a very good device with a lot of trackability profile. Nobody complained about the device, and yeah, the only thing is that you have to inflate longer, but. Yeah. This is something minimal, except in left main, as you say. Yeah. But let's say
stents.
Yeah, indeed, if I can actually address this point, I would say that, in a sentence, that macroscopically is just like another stent.
Yeah.
Microscopically, there's a lot of differences, particularly in the technology that, we are discussing since half an hour. What some ideas that have been translated into practice with this technology might be the solution to tackle this problem of diabetes. Obviously, I don't have the data. We're waiting for the data, but microscopically, in the details, probably lies the solution. Well, obviously, we'll see, but I can tell you that, I started using this device since 8 years, more or less, and I have to say that it looks like another stent, just like another stent. Nevertheless, the promise for diabetic patients is still there, and obviously, I hope that this promise will be fulfilled, but, we'll see.
So Luca, I've got the concept's great, and I think you pointed out some tremendous case. That was a very good case of in-stent restenosis, and diffuse in-stent restenosis is a very difficult problem to tackle, especially if it's recurrent. Now, I have a question for you. I do agree about the use of a drug-eluting balloon for diffuse in-stent restenosis, but we also realize that Zyme stent has been shown to be superior for in-stent restenosis than just a DCB, which is still not clearly,
I agree.
There. Some of the concepts which I've tried to do in the past, of course, is that if it is diffuse and it's at an important situation, I've used a drug-coated balloon followed by a everolimus-coated stent. And that seems to work far more efficiently in small vessels, in diffuse in-stent restenosis. This brings me to the point of your use, that if you've got a stent which actually has drug-coated balloon as well as sirolimus solution, stent and its thin strut seems to be a good one for a diffuse in-stent restenosis as a philosophy. What do you?
I was about to say, as a philosophy. Obviously, I would like to have data to show and discuss with you. But what I'm trying to understand is the specific place of this technology in several settings. Of course, talking about these extreme cases, and I just showed. Well, honestly, I don't have a clear-cut answer. To be honest, I don't have it. And basically, what I'm trying to say is that, if the technology directly translates into practice, we got, some, basics to do that. Nevertheless, you've seen a lot of concepts, theoretically good concepts and then they failed in practice. So in that specific case, to be honest, my approach is to reduce the amount of metal as much as possible. But you're right when you say that this thin strut combination with drug might be the solution. That was Zyme that failed. So, I'm still waiting for another answer.
Well, I think it also depends on the mechanism of in-stent restenosis, right? But what is probably safer in your approach is that, as we said before, it's not a double dose of drug, it's an even dose of drug. So if you're doing what you've done in your case, and I hope it turned out well, you were actually delivering double dose of different two drugs, right? So
absolutely.
Yeah. But I guess, as you said, we need evidence, not just nice cases. So without further ado, I'd like to invite one of the co-chairmen of the Global Ability Diabetes Trial, Professor Marie-Claude Morice, to talk about the trial.
Thank you, Joanna. Thanks a lot. Okay. Sorry.
good evidence always requires a bit of a pause and a wait, right? If you want to gather really good data.
Okay, thank you for the help. So, I'm here to speak, as written, world largest randomized trial for diabetic patients. This is not nothing, really important. These are my disclosure. You all know that diabetic is something severe, but to illustrate, you reduce as soon as you are diabetic, you reduce your life expectancy from 6 years, which is a lot. And if it's added to cardiovascular disease, your life expectancy is reduced for 12 years, meaning that every single progress that you make in that particular disease is life expectancy above quality of life. And as you know, there is an explosion of the cases of diabetic patients worldwide. You saw this slide. Diabetic patients have more events than the others because of the delayed vessel healing, the slow endothelialization that make restenosis more frequent, and the risk of acute subacute stent thrombosis also more frequent. You saw about the technology. I won't insist on that. It's you have an edge coating. You have a biodegradable film that goes in the wall. And really, this device was designed to treat a diabetic patient. And the hypothesis of the study, designed by your chairperson who is there, my friend Roxana Meran, was that by providing more drug and greater drug, more homogeneous drug delivery per millimeter square at the vessel wall will result in a reduction of restenosis at 1 year in the diabetic patient. So the study objective was to compare the efficacy and safety of the Abluminous DES+ Sirolimus Eluting Stent versus the Everolimus Eluting Stent in diabetic patients, elective for PCI. We expected 40% multivessel disease because of the diabetes and 30% acute coronary syndrome. And the study design is as follows. The patients are diabetic, they are eligible, they were followed 30 days, 6 months, 12 months, 24 months in a prospective, multi-centric, randomized, one-to-one, open label at implantation, but blinded during follow-up. And primary endpoint, IDTLR at 1 year, powered for non-inferiority and sequentially superiority if non-inferiority is met. 20 countries, 86 sites in Asia, Europe, and Latin America, 3,050 patients recruited with, as said, Abluminous versus Xience. As said, it's important. There will not be bias by knowing how the patients were treated. As soon as PCI is performed, all the people that do follow-up are blinded to the study arm. And the patient can be diabetic, a known diabetic patient, but also newly diagnosed diabetic. And they can be any symptomatic coronary artery disease, chronic, silent, non-ST elevation, where only, and of course, they can have one or more lesions. There was no limitation of the number of treated lesions, number of vessel, or lesion length in this trial. So you see really wide open to all patients, diabetic patients with coronary disease. We excluded only the cardiogenic shock, the STEMI patient for consent issue, and the severe renal dysfunction. As said, the primary endpoint is ischemia-driven TLR at 1 year, and also target lesion failure, also powered for non-inferiority. And of course, we will look to several safety composite endpoints and also to the bleeding. We will look also to the stroke, to the stent thrombosis in both arms, and of course technical and procedural success. How this study is managed? Very seriously. Very important trial, 3,000 patients, so it has to be well managed, and it is. The sponsor is Concept Medical. Then they provide the study device, of course. Mount Sinai, ICANN School of Medicine at Mount Sinai, was in charge of project management, site selection with us, CEC, DSMB, data management, and the stats. And at CER, in Europe, we work on all regulatory submission all over the world, project management, contract with sites, monitoring, SIA reporting, and core lab for endpoint-related events. This is the executive management of this trial. Our chairperson, Professor Roxana Meran, and with as 3 PI, Professor Colombo, Abi Zaid, Siguro Saito. And I'm happy to join the executive management. And we have a wonderful steering committee added to those persons that has Fazila, Malik, here present, Professor Edith Smith, Dudek, Tolg, and Benjamin Faury. There is a CEC committee continuing to educate on a regular basis all the events that you see there. Dr. Marx is the chairperson, and there is Darrow, Weinberger, Dr. Di Stefano, Milsten, Shah, Kaufman, and Brenner as CEC member. There is a DSMB chaired by Dr. Deepak Bhatt with Spencer King, Stuart Pocock, Timothy Collier as non-voting member in charge of the stats. And 2 DSMB took place, and they say that the study can continue as planned. We have 86 sites, as said, open that recruited, 79 in Europe, 2 in Latin America, and 5 in Asia. And this is the recruitment. We finished last week, September 9th, the end of the recruitment. More than 3,000 patients recruited during this COVID period. And really, all sites must be extremely congratulated for having done that. The largest recruiter, and happy to have Professor Malik here. Bangladesh, you are the first in recruitment, just behind Brazil, that were extremely effective also after Netherlands. So you see, you have everybody there. Huh? Then North Macedonia, Germany, France, Malaysia, Italia recruited very well also. Then Switzerland, Austria, United Kingdom, Poland, Czech Republic, Sweden, India. To conclude, ladies and gentlemen, diabetic patient is increasing worldwide and continue to have a poor outcome despite all medical improvements so far. The Abluminous device represents the combination of a DES and a DEB with the advantages of both systems and has the potential to address better this particular population. And the Abluminous Diabetic Global Trial is the largest head-to-head stent trial for diabetic patients conducted so far. Patients were recruited all over the world, and we allow the result to be valid everywhere. Thanks a lot.
Congratulations. That's an amazing effort, I think, for everybody. And Roxana and Marie-Claude will be then expecting results with 1-year follow-up at TCT next year in San Francisco.
We hope so. That's the plan. And we are also planning to go out to 2 years. So we'll start at 1 year, but then back again at 2 years as well. So investigators will be with us, and we'll have longer-term follow-ups going forward.
Wonderful. Any other questions for Marie-Claude about the trial? I think all of us have included patients here, so we have an unfair advantage of knowing what the trial is all about. So perhaps to conclude and to give us some take-home messages, I'll invite the chairman, Dr. Roxana Mehran.
Thank you, Joanna. Ladies and gentlemen, all of you listening to this wonderful symposium addressing a very, very important issue, coronary artery disease in diabetic patients. We heard the incredible evidence that diabetes is increasing worldwide. And when you have diabetes in combination with coronary artery disease, we just heard that you take 12 years away from your life expectancy. To address these issues, and at the moment, any diabetic patient with multi-vessel disease, our guidelines are telling us that we should be considering bypass surgery. Many of these patients do not want to undergo bypass surgery because current generation DES has not been able to address the issues really well in diabetic patients. We see a lot of stent failure and recurrence. And of course, stents don't treat the entire vessel, they treat the lesion, and we'll always see some benefit of perhaps bypassing the vessel. But in our diabetic patients who are amenable to PCI, we really look forward to DES next generation with some technology that will address the aggressive neointimal hyperplasia that diabetic patients experience. We heard today a very exciting new technology with the drug eluting stent combined with a drug-coated balloon with a sirolimus solution on a biodegradable polymer on a thin strut that's deliverable to address this issue for diabetic patients. And we heard loud and clear that we put this stent against the best in class in terms of a prospective, well-powered, randomized clinical trial with independent adjudication, independent data safety monitoring board, and absolutely looking forward to the results. We must have better solutions for diabetic patients, and I think, and I'm hoping, very well that this particular technology may have some of the answers, certainly to deal with the target lesion revascularization issues compared to the current technology that we have at hand. I want to thank our fantastic speakers and discussants and experts here, and all of you for listening and caring about this important issue for our patients with diabetes. Thank you so much for your attention.